I'm Leslie Blankenship-Williams, and we are going to finish up our topic of process of infectious disease. Now, like the previous lecture, this particular recording is going to contain a variety of topics that may feel a little bit disjointed, and there's a lot of terminology. So I strongly recommend that you have a writing utensil and some paper to take good notes. Make sure that when you're taking notes, you not only write definitions down, but also think about ways to apply those definitions to real diseases. So in this lecture, we are going to look at how bacteria and viruses actually cause the disease. You might think that's an obvious answer, but really, if you get a bacterial infection, how do all of those symptoms that you get come up? When you get a virus infection, how do all of those symptoms arise? And that's going to be the question that we are going to address. Then we're going to turn and take a look at the stages of infectious disease. And then we're going to turn and take a look at a totally different angle of infectious disease, and that is epidemiology. And epidemiology also encompasses the idea of transmission, which is how does a pathogen jump from one person to another person. As part of understanding transmission, we need to understand reservoirs, we need to understand mechanisms of transmission, and we need to understand portals of entry and exit. So let's get started. We are first going to take a look at bacterial infections. Now, in this class, we have an entire module dedicated to looking at the various species of bacteria that cause infections and what types of infections they cause and often how they cause them. So what I'm going to do is give you a general strategy that most bacteria employ to cause infectious disease. Let's take a look at an animation. One of the critical tenets to bacteria causing infectious disease is that they need to be able to attach. Imagine that a little bacterial cell is in the vicinity of these human cells in brown, but it doesn't have a place to attach. That bacterial cell is going to be basically washed away. But if it can attach, now it has a home, and now it feels safe and secure, it can stay attached, and it can replicate. And all of the other cells can also somehow stay attached. So once that happens, now you've got a population of bacteria and they can cause an infection. Most bacteria stick to the outside of our cells somehow. And when they stay in the extracellular environment or the external environment, we call them colonizers. So most bacterial species that are pathogens are colonizers. But it turns out that that's not the only way that bacteria can get into our bodies. Some bacteria are capable of actually penetrating our cells and getting inside of our cells. And when that happens, they're able to replicate inside of our cells, and we call those invasive bacteria. So typically invasive bacteria are a little bit more problematic than colonizing bacteria. Now, if the bacterial species is invasive, it will also spend some time out of the cell as well. So most bacterial species are colonizers, but some are capable of penetrating our cells and being invasive. So to summarize, it is important for bacteria to be able to attach to some part of our cell. So attachment is critical in causing disease. In a prior lecture, you learned that fimbria were critical for E. coli causing urinary tract infections. So that's a pretty strong example of how important it is for bacteria to be able to attach. Most bacteria stay in the extracellular environment or the external environment, meaning they stay outside of our cells. And any bacteria that do this, which is most of them, are referred to as colonizers. Some bacteria are capable of going inside the cell. We call that an intracellular environment. So intra means inside. So in the cell, Neisseria gonorrhea is one, of course causes gonorrhea. Yersinia pestis, which causes plague, is another. Mycobacterium tuberculosis is a third. So those are examples of bacteria that are capable of invading our cells. For this particular test, you will not need to know those examples, but I'm just giving them to you so you understand that there are some bacterial species that are capable of getting into our cells, but it seems to be a little bit more of the exception rather than the rule. If bacteria are capable of getting into our cells, we call those invaders, and then usually they'll spend some time in our cells and sometimes out of our cells. Okay. Here's another picture that looks at attachment. You can see here fimbria are used to attach, and then sometimes they can use slime layers or capsules also to attach. Those are different mechanisms that bacteria might use to attach to our cells. But again, the important thing is that it's critical. If bacteria are unable to attach to our cells, then chances are they're not going to be able to cause disease. So for that reason, if we have a mutation, for instance, that renders bacteria fimbria incapable of being synthesized, then that bacteria may not be as pathogenic. And of course, anything that allows bacteria to attach is going to be a virulence factor. Once bacteria attach to our cells, how do they actually cause disease? Well, replication is part of it, so usually they're going to replicate and make a lot of bacteria. And then what? Let's take a look. One thing pathogenic bacteria are really good at is secreting toxins. Toxins can have a lot of different effects, but one effect that toxins might have is to actually damage the cells. In this animation, the toxins are red dots. And when they land, they actually damage the plasma membrane and the junctions holding cells together. And this allows bacteria that were in the external environment to actually penetrate into the cells and sometimes get into our deeper tissues. And this is how bacteria like staph can migrate from our skin into our bloodstream. So let's summarize different ways that bacterial infections can cause the symptoms of disease. So many bacterial species secrete toxins. In a prior lecture, we learned about the difference between endotoxins and exotoxins. Exotoxins are purposefully secreted, and exotoxins can cause harm to our bodies, usually by one of three ways. And these are not necessarily mutually exclusive. One toxin can have multiple effects, and moreover, certain bacteria can secrete more than one type of toxin. So the three general categories that I see for exotoxins are going to be interfering with some form of our human physiology. So for instance, if we have a skeletal muscle that we need to contract, and we have botulinum toxin, which is going to be a toxin secreted by a certain species of Clostridia that causes botulism, then we know that our muscles become flaccid and they're unable to contract. Of course, the problem with that is your respiratory muscles are needed for breathing, so if they also become flaccid and are unable to contract, that's fatal. So certain toxins can interfere with our physiological functions. Other toxins end up aggravating our immune system in kind of a detrimental way. As we are going to learn, the immune system is not the most elegant system in the world, and a lot of times it can be poked and prodded and gets kind of angry and discombobulated and ends up causing more harm to us than help. So some toxins are actually primed to like poke the bear, gotcha, 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 and our immune system just gets really angry and discombobulated and starts kind of having a fit of rage, and it ends up causing some serious problems for us. And then third, as shown in the video, you can also just damage the tissues. And this is one way that you can cause cellular death, or you can eat away at junctions holding cells together and get down into deeper tissues. So for instance, that might be a way that a staphylococcus infection on your skin gets into the bloodstream and causes a blood infection. Now, bacteria secreting toxins is certainly a major theme in bacterial infections, but it's not the only thing that can be going on. Many times your immune system just has a response to the sheer number of bacteria, or maybe where they are. So for instance, in urinary tract infections, E. coli may not be secreting a toxin, but the fact that they're in your bladder and possibly getting up into your kidney doesn't make your immune system very happy. Your immune system has a response to their presence, and the response generates a lot of the symptoms of disease. A classic example of this would be pneumonia. Most cases of bacterial pneumonia are caused by bacteria that are in the air spaces, and our immune system starts the process of inflammation when it senses those bacteria. As part of inflammation, fluid fills our lungs and makes it more difficult for us to exchange oxygen and CO2. And so the symptoms of pneumonia, getting fluid in your lung, are really the result of our immune system trying to combat the bacteria that are down there. Now that we've looked at bacteria, let's take a look at how viruses do it. So let's watch a quick video on how viruses infect our cells. Like bacteria, attachment is an important part of the disease process for viruses. Viruses absolutely must attach in order to be infectious. They usually bind to some sort of receptor on our plasma membrane. Once they do that, then they can actually get inside of our cells. So all viruses get inside of our cells in order to cause disease. Once they're inside of our cells, they reprogram our cells to basically stop doing what the cells are supposed to be doing and start doing what the virus wants it to do, which is make a whole bunch of new viruses. Eventually, the viruses are going to exit the cell. In this case, they actually lysed our own cell in order to exit. So let's summarize what we just saw. Whereas bacteria usually need to attach in order to cause disease, but it's not 100% of the time, it is 100% of the time for viruses. Viruses must attach to your plasma membrane, usually through a receptor, in order to be infectious. Full stop. If they cannot attach, they cannot infect. Once they attach, they somehow get into our cells. How they get into our cells will be saved for a later topic. But once they get inside of our cells, they hijack them. And when they hijack them, they basically reprogram the cell to stop doing what the cell was supposed to be doing and start doing what the virus wants it to do. And then the virus, of course, needs to somehow exit the cell. And when it exits the cell, it can sometimes lyse our own cells as well, but not all viruses do this. In this image here, you can see viruses, and those are going to be the circles, are exiting the cell via a process known as bedding. So they actually bed off, almost like blowing bubbles. And so the human cell does not lyse in this case. Regardless of how they get out of the cell, the next step for them is going to be to try to find a new cell to infect and rinse, repeat. So where do the symptoms of disease come from when you are infected with viruses? Well, viruses don't secrete toxins like bacteria do. So the symptoms of disease are a little bit different. In general, viral disease produces symptoms by one of two mechanisms. And again, these are not mutually exclusive. You can have both of them. One of them is by preventing our own cells and tissues from working properly. And again, because that cell or tissue is now working for the virus and no longer for you, you can lose the function of that cell. So an example of this would be HIV and AIDS. HIV is a virus that infects our helper T cells. As you are going to learn in immunology, helper T cells are critical for our immune response. Because our helper T cells are infected by HIV, those helper T cells no longer work for us, and therefore you lose your entire immune response because the helper T cells are no longer doing their job they're working for the virus instead. So as a consequence, you develop the disease AIDS, which is acquired immunodeficiency syndrome. So again, immunodeficiency means that you are now unable to mount a full immune response because of the HIV virus. Sometimes they actually destroy our own cells or tissues by lysing them, and that's part of their exit strategy. Alternatively, our immune system can identify infected cells and destroy them as well. So very often, the disease produces symptoms when the cells are destroyed. And then along that line, we have our immune response. So when you have lysed cells, our immune system doesn't like that and will create an inflammatory response that can produce symptoms. But another thing that viruses do, and some of the more lethal viruses, I'm thinking of coronavirus SARS-2, for instance, are really good at discombobulating our immune response. In other words, they're excellent at taking our immune system and basically disarraying it, causing a lot of infighting, causing it to go on wild goose chases, etc. And again, because discombobulated immune systems kind of go into this fit of rage, a lot of times that can cause problems to us. Okay, so now that we've looked at a general theme about how viruses versus bacteria cause infection, let's talk about disease process. So I want you to think about a disease that you have had recently, an infectious disease. Unfortunately, if you have had COVID, it doesn't always follow this particular trajectory. So instead, I want you to think of something like a cold. Almost everybody has had colds. So when you have a cold, you have an inoculation event. This is the time that you actually get inoculated with that particular virus. So let's say that the inoculation event occurs where the arrow is. Okay. So then what happens? Do you get sick like within a minute? Somebody sneezes on you and you're sick the next minute, 2 minutes from now, 3 minutes from now? Of course not. There's a delay, there's a lag period. So initially, nothing happens other than if you knew you got sneezed on, you might be a little bit worried that you're going to get sick, but you show no symptoms. Then, sometime later, could be hours, it could be days, sometimes it could even be weeks. You start to get sick. You start to show symptoms. The symptoms don't come on immediately and heavy hitting. Usually they come on kind of gradually and they build. So maybe you're just like, gosh, I'm really tired today, or I feel like I've got a scratchy throat, or I have a little bit of a headache. And so the symptoms kind of start going up, but they're non-specific, meaning, you've got a scratchy throat, you've got a little bit of a headache, you don't feel well, what do you have? Well, you're probably coming down with something, but you don't know what it is yet, because what I just described could fit so many different diseases out there. A little tired, maybe a little feverish, not feeling so well, a little nauseated, maybe a little bit of a runny nose. It could be hundreds of different things. And then the symptoms continue to get worse. And then you know exactly what you have. You have a fever. You have a runny nose. You have a really bad cough. You have a headache. You're pretty sure it's probably the flu, or it's SARS, or it's a cold. But it's not going to be cholera, for instance. It's not something totally different. You're like, no, I've ruled that out. I'm now in the respiratory infectious mode. Something respiratory has taken a hold of my body and I feel awful. And the symptoms continue to go up, 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 up. And eventually you're going to kind of hit, here it's a peak, but from your own perspective, it's your low spot. You're going to hit rock bottom in terms of symptoms and just be like, oh, I feel so awful. I feel so awful. And then hopefully your immune system will get a toehold on that disease and start fighting it back effectively, at which point your symptoms are going to start declining again. And so maybe one day you wake up and you feel a little bit better, and then the next day you feel even better. And then a couple days later, you still notice that maybe you've got some phlegm, or a little bit of a scratchy throat, like you can hear right now for me, but you don't feel nearly as sick. So what I just described is very typical. It's a very typical disease process. And because it's so typical and it applies to so many different infectious diseases, nearly all of them, we have given names to these various stages. So when I started this conversation, I said we're going to get inoculated and then there's a lag time. That lag time is known as the incubation period. The incubation period is defined as the period between inoculation and when symptoms start to show. So everybody is familiar right now with COVID. The incubation period for COVID is considered to be 2 to 10 days with an average of about 5 days. In other words, if you start to show COVID symptoms, you were probably exposed somewhere around 5 days ago. Might be as early as 2 days ago, but it could be as long as 10 days ago. And then the symptoms start to creep up. You start to feel unwell. But again, the symptoms are going to be non-specific, meaning you don't really know exactly what you have. You can't pinpoint it. You might have suspicions, but you're not for sure. And we call this phase prodromal. The prodromal period is marked between the onset of symptoms and a period of what is called invasion or the real illness, where you have all of the textbook symptoms that are going to be affiliated with your disease. So prodromal is considered to be usually mild, the early onset, and non-specific. Things like I'm tired, I have a little bit of a headache, I don't feel so well, I'm not very hungry, that kind of stuff. Because it applies to so many different infectious diseases. You can't really be sure what you have. And then the real symptoms hit. And we call that period the invasive stage. Sometimes it's also called the period of illness. So different books call it different things. So invasive or period of illness. And this is where the specific symptoms show up. So if you actually have COVID, you have a loss of taste or a loss of sense of smell. You start having tightness of chest, your oxygen levels go down, you have a raging headache, maybe you have some diarrhea, you might get like little rashes, bumps, you could have little blood clots, you could have COVID toes, et cetera, et cetera. These are all things that are rather specific when taken as a whole to COVID. And that's how you would say, no, I'm pretty sure I have COVID and not the flu or not a cold, it's not allergies, etc. And then, hopefully, your immune system starts winning that battle and your symptoms start to decline. And so this is known as the decline period. You're still feeling pretty under the weather, but you're not as sick as you once were. And then you heal mostly, and you might have some lingering symptoms in there, and we call this the convalescent period. Now, I mentioned that COVID doesn't always follow this, and that is true. Some people have exactly this trajectory, but not everybody. If you have a fatal version of COVID, unfortunately, you never hit the decline or the convalescent period. Some people have recurring COVID, so they get sick, and then they feel like they get better, and then they get really sick and they end up in the ICU. So when I say this is kind of a general trend, not all diseases follow this exactly this way. But because most do, we have terms for it. Again, make sure you're able to apply these terms. On the test, instead of asking you to define something, I'm likely to give you the symptoms of a disease. Here's a disease. Here's all of these different properties of the disease, between when you first get inoculated and when the onset of symptoms starts is 7 days. You should know then that 7 days is the incubation period. So you need to be able to apply these terms to a real disease process as described to you on the test. So here's another look at kind of that same thing. They don't have the convalescent period broken up into decline and convalescent like I do. But it brings up this question: when is a person contagious? Well, you know what? That is an excellent question, and one that is answered by it depends. It depends on the disease. So interestingly enough, the symptom severity often correlates to the number of viruses or bacteria in our bodies. So for instance, if this represents like somebody's flu or cold or COVID, when you're here, this should be the highest number of viruses that person has, where a person has a lower number of viruses here and even lower number here, and again, lower number here. The lower the load of viruses or bacteria in your body, usually the less contagious you are. Unfortunately, it's not always that clean or clear. Sometimes a person can be very contagious in the incubation period. Sometimes people are contagious in the convalescent period. One of my pet peeves is when somebody gets on antibiotics for bacterial infection and says, "Oh, I'm not infectious, I just started antibiotics." I said, "Really? Five hours ago?" Yeah, your symptoms might be starting to decline, but you still have live bacteria that are trying to get into a new person. So don't tell me you're not infectious. You might be a little less infectious than you were 5 hours ago, but that doesn't mean zero infectivity. So let's talk about COVID for a moment. I'm reading a really interesting book called Spillover, which talks about, and this was published pre-COVID, but it was basically about the next great pandemic. And SARS is in there as possibly one of the culprits, as is bird flu. But one of the arguments that the author makes is this one. The next big one, the next big pandemic that we see, which we are seeing now, is probably going to have this characteristic. Asymptomatic people will be infectious. In other words, people in the incubation period will be infectious. And guess what? That's exactly what we see with coronavirus SARS-2. Now, why does that make it a prime candidate for a pandemic? If you're spreading the disease when you're asymptomatic, you yourself, if you're that person, don't know that you're infected and therefore are not quarantining or taking precautions. Of course, now we know that, if you think you've been exposed, you should quarantine, etc. But not everybody adheres to that. Not everybody knows when they've been exposed. If you're going back to school 2 days a week, you possibly are being exposed. But you can't quarantine for 10 days every time you go to school for a day. It's just not feasible. So I think it's really interesting that this book, again, highly recommended, it's called Spillover, basically predicted that the next big one was going to have that feature, and coronavirus SARS-2 has that feature. So that's an example of a case where somebody in the incubation period is infectious. But in general, the more symptoms somebody displays, the greater number of viruses or bacteria they're harboring, and therefore the more contagious they are. That's a very general rule. But don't rule out that somebody can't be infectious in the convalescent period or can't be infectious in the incubation period. There are certainly diseases where you can be infectious in one or the other, or possibly both. I really like this particular graph because it shows how wide-ranging the incubation periods are for different species. You're not responsible for memorizing any of this, but I want you to take a moment to take a look at it and realize that there's a great variety. Now, the incubation periods, which are specific for each disease, also can help you diagnose infections. So consider this example. Imagine that you have a child who's been admitted because she's showing kind of weird neurological inflammation. And you suspect that maybe she has rabies. So you ask the parents of this child, has she been bit by a wild animal recently? And they say, well, yeah, actually she was bit by a dog yesterday. Well, that's not going to qualify because if you look here, the incubation period for rabies is between 14 days and a year, but really it's usually 14 to 21 days is typical. So yesterday is too soon. But if the parents instead say, actually, yeah, she was playing outside and she got bit by kind of an angry raccoon 2 weeks ago, don't rule out rabies because it fits the incubation period. And if you know anything about rabies, early intervention is critical to saving lives. If you wait too late, it's automatically fatal. Okay, again, you're not going to need to memorize anything on here. I just think it's really fascinating because it not only does it show you that there are different incubation periods for different diseases, but also that you can use your knowledge of those incubation periods to help you kind of tease out what the infectious agent might be if somebody is presenting with specific symptoms. One more thing I want to mention, and that is the idea that convalescence doesn't necessarily mean unable to transmit. And the first case that was well documented of what is called a convalescent carrier, in other words, somebody who is not showing symptoms but seems to be carrying the disease regardless, was a woman unfortunately named Typhoid Mary. Her real name was Mary Mallon. And Mary Mallon carried Salmonella typhi somewhere in her digestive system. They suspect it was the gallbladder, but they don't know. She herself did not show any symptoms. There are differing reports on whether she got typhoid fever and then recovered, or whether she was born this way because her mom was infected with typhoid fever when she was in the womb. We don't know. All we know is that she was a cook. And she didn't wash her hands because it wasn't common at that time. So she would poop, not wash her hands, have Salmonella typhi all over them, and then prepare food and put the Salmonella typhi all in the food. And then the people would eat it and they would get typhoid fever. And 3 people died. And as soon as an outbreak of typhoid fever happened, she would jump to another house and become a new cook. Eventually, she started changing her name, and she was actually imprisoned twice because she refused to stop cooking. The second time was permanent, and she was imprisoned until she died. So she's infamous, against her will, by the way. She was very upset that she was labeled this way. But she's infamous for being perhaps the first known and well-documented example of an asymptomatic person spreading disease around. And so again, she got the unfortunate moniker Typhoid Mary. All right, we're going to pick up this lecture in the next recording.